Hello friends, in this video I am going to discuss about one of the interesting is finding, that is Wolff-Parkinson-White pattern. So there is two terminologies, Wolff WPW pattern and WPW syndrome. What is WPW syndrome? WPW syndrome is a clinical entity characterized by pre-excitation of the ventricles with symptoms of paroxysmal tachycardia. There has to be symptoms of paroxysmal tachycardia. If there are no symptoms of paroxysmal tachycardia, it is just WPW syndrome. So what are the ECG features of WPW syndrome? So pre-excitation of the ventricles means before expected ventricular depolarization, there is depolarization of the ventricle. So that means there is a short PR interval. So one ECG finding is short PR interval. See here, this is starting of the P and starting of the Q. There are hardly two boxes. It's zoomed here. Starting of the P, starting of the Q. So 1, 2. Only two boxes. That is 80 milliseconds, which is less than 120 milliseconds. So there is short PR interval, and there is, you see here, these are your delta waves. Delta waves are nothing but slurred upstroke of initial part of the QRS R wave. Slurred upstroke of the initial part of the R wave. So that is called as delta wave. Next is these ST-T wave changes. You see here, these ST-T wave changes are discordant to the delta wave. What I mean by discordant means, if the delta wave is positive, ST-T wave changes are negative. So these are called as discordant ST-T wave changes. So these are the three ECG findings of WPW pattern. If they are associated with clinical symptoms of paroxysmal tachycardia, then it's called as WPW syndrome. So what is happening in WPW syndrome? See, normally this is normal. This is what is happening in WPW syndrome. So normally what happens? There is a fibrous tissue around the junction of the atria and ventricle. So these are your atrias and this is your ventricles. In between the atrioventricular junction, there is fibrous tissue. So this fibrous tissue doesn't let the atrial impulses travel to the ventricle in this way. So making only AV node as a electrical window between atria and ventricle. So if atrial impulses has to travel to the ventricle, that is through the AV node only. So no other current travels between atria and ventricle other than going through the AV node. So in WPW syndrome, what happens? There is a bypass tract or accessory pathway. That means current from the atrial impulses will go through the AV node as well as that accessory pathway. Okay, so there is presence of one or more bypass tracts. So these bypass tracts make the ventricle excited before the normal conduction depolarizes the ventricles. So let's look at how the depolarization happens. Let's suppose this SA node is generating the electricity, and this SA node travels through the AV node as well, and it travels through the bypass tract. When it travels through the bypass tract, there is no delay like in AV node. So it reaches the ventricle before the AV nodal current reaches the ventricle, so that excites the ventricles. This part of the ventricle is excited. This is pre-excited ventricular tissue, and by the time AV nodal current reaches the ventricles, this part is depolarized. So the atrias are depolarized normally because there is no abnormality in the atria. So you get normal P wave. So when this part of the ventricle is pre-excited, before the current reaches the ventricles, this part is already pre-excited. So there is positive, and this is a myocyte conduction. So it is delayed. So there is positive slurred upstroke. That's why you get delta waves. So I will repeat once again. This part of the ventricle is pre-excited before the AV nodal current reaches the ventricle. So this part which is depolarized, that causes, see, there is depolarization, so upstroke will be seen. And it is slurred because slurred means taking time, that because these are myocytal conduction. Myocytes are poor conductors, are slowest conductors. Purkinje fibers are your fastest conductors. So when the current from the AV node, impulse from the AV node reaches the ventricles, it will cause normal rest of the QRS. So in total, QRS looks wide because of this delta waves. Next, this is how the impulse travels through the bypass tract and AV node. So the size of the delta wave is based on the amount of ventricle pre-excited or pre-depolarized by the bypass tract, and that is depend upon the location of the bypass tract. See, so let's look at the size of the delta wave. See, this bypass tract is present on the left side and this is present on the right side. What is happening? Left side means it is farther away from the SA node, and right side means it is near to the SA node. So when SA node generates the electricity, it goes to the AV node and it as well as goes to the bypass tract. By the time it bypasses the, by the time it reaches the bypass tract and reaches the ventricles, the AV nodal current would have been reached the ventricles. So there is little depolarization of the ventricles. The amount of ventricle depolarized by bypass tract is very small. So you get small delta waves or there is no delta waves. Okay, that means these bypass tract can be concealed or they are not seen, they are not recognized nearby ECG because the delta waves, they are dependent upon the amount of ventricle depolarization. Let's suppose in this case right sided bypass tract, what is happening is SA node is generating the electricity which is going through both bypass tract, right sided bypass tract as well as AV node. So before AV nodal current reaches the ventricle, the bypass tract depolarizes the major chunk of the ventricle. See here, this part is compared to left side, see here, and right side, there is amount of ventricle depolarized by right sided bypass tract is much more compared to left sided bypass tract. So there is bigger delta waves. Okay, so if you are seeing a prominent delta wave in ECG, it is nearer to the SA node. That's all it says. Okay, so let's look at this some features about the bypass tract. So bypass tract, unlike his Purkinje system, bypass tract consists of ordinary heart muscles. They are not specialized conduction cells, they are just ordinary heart muscles, myocytes, and does not contain cells that are specialized for conduction. So the bypass tract may be left sided or right sided, anything can happen. So it may be single or multiple. It's not necessary that bypass tract should be only one. Conduction may be constant or intermittent, and the bypass tract may be active or inactive. Bypass tract may not conduct any electricity. So bypass tract may conduct only anterogradely from the atrium to ventricle or retrogradely from the ventricle to atrium or both. Some bypass tract will conduct only anterograde and some bypass tract only conduct retrogradely, that is from ventricle to atria, or some may conduct in a both manner. And this location of the bypass tract varies. So location of the bypass tract may varies, and most commonly they are present on the left ventricular free wall of the left ventricle. That is 50 to 60% of the bypass tract are present on the left ventricular free wall, and 20 to 30% they are present at the posterior septal area, either left or right posterior septal, and 10 to 20% present on the free wall of the right ventricle. So free wall of the left ventricle is the most common. Next is posterior septal. Next is free wall of the right, and the remaining 5% are located in the anterior septal area. So you have to remember it is on the left free wall. So let's look at the locations of the bypass tract. This is anterior septal, this is posterior septal, and these are left ventricular free wall, right ventricular free wall. So most common is 50 to 60%, that is on the left ventricular free wall. Next most common is 10 to 20%, that is posterior septal. Next is your right ventricular free wall. After that your anterior septal. So you have to remember that is most common is left ventricular free wall. So can we recognize the location of the bypass tract on ECG itself? Yes, we can recognize. So for that you have to see lead V1. Lead V1, what you have to see is the delta wave, whether it is delta wave is predominantly upward or that delta wave is negative, whether delta wave is negative or positive. So see what happens if this is right sided bypass tract and this is left sided bypass tract. What is happening in right sided bypass tract? The impulse comes and it goes through the bypass tract and depolarizes this part of the ventricle, and the impulse as well as comes, it depolarizes the atria and it reaches the AV node and it goes to the bundle of his and bundle branches and depolarizes the ventricle. By the time AV nodal current depolarizes the ventricle, this much part of the ventricle will be pre-depolarized or pre-excited by the R wave. So I mean the bypass tract. So here is your V1, here is your V6. This is the orientation of chest leads. So this current from the pre-excited myocytes, pre-excited ventricle will travel like in this direction. So it is going away from the V1. One basic thing I want you to remember is, if the current, let's suppose this is your electrode, if the current goes towards the electrode, it is perceived as positive deflection, that is positive wave. If the current goes away from the electrode, it is perceived as negative wave. So in this case, the pre-excited ventricle current is traveling is in all directions, which is away from the V1. So here it is perceived as negative. So you get negative delta wave. Okay, so negative delta wave. Similarly, in left-sided bypass tract, what is happening is, see, current from the AV node is traveling through the, current from the SA node is traveling through the AV node as well as bypass tract. So this bypass tract is depolarizing this much part of the ventricle, and here is our V6, orientation of V6 and V1. This current is going like this, and this current is going towards the V1. So there is positive delta wave in V1. So positive delta wave in V1 means left sided bypass tract. So let's look at the ECG, what is happening here. First we have to identify whether it is Wpw syndrome or not. So for that you have to see there is short PR interval and presence of delta waves and discordant STT wave changes. So short PR, delta wave and discordant STT wave changes. So these are the features of Wpw syndrome. Once you diagnose the Wpw syndrome, you have to localize the bypass tract. For that, you have to first see is lead V1. In lead V1, the delta waves are negative here. In lead V1, the delta waves are delta waves are negative. So that means it is current is going away from the V1, that is on the right side. So this bypass tract is present on the right side. So once you know it is on the right side, you have to know whether it is on the right posterior septal or right free wall or right anterior septal. For that you have to see axis. Here axis is left axis deviation. So when it is left axis deviation, it is not anterior septal. In anterior septal, axis is normal. So left axis deviation is seen in posterior septal and free wall. So how to differentiate that? So for that you have to see lead 2. In lead 2, if the delta waves are predominantly negative, it is suggestive of posterior septal. But here it is biphasic or predominantly upward. So it is not posterior septal, it is free wall. So this is right ventricular free wall. Bypass tract is present on the right ventricular free wall. So compared to here, what is happening here is, see, there is short PR interval and delta waves and STT wave changes are discordant. So, and see here what happened. These delta waves are not that prominent because it is on the left side. Compared here, see, they are so much very prominent. So once you diagnose this as Wpw syndrome, you have to localize the bypass tract. You have to, for that you have to see V1. In lead V1, there is positive delta waves. Positive delta waves in V1 means the bypass tract is present on the left side. Now you have to differentiate whether it is on the posterior septal or free wall of the left ventricle. For that you have to see the 2,3 AVF complexes. 2,3 AVF, this is biphasic or predominantly upward, and there is LAD. So it is present on the left ventricular posterior wall. Next, so let us see some more examples for localizing the AP. So there is so this is the diagnosis of Wpw syndrome. So here we are only localizing the AP accessory pathway. For that you have to see lead V1. Here it is predominantly up, that is positive delta wave is present one, so it is on the left side. So next you have to see is lead 2,3 AVF. See, there are positive delta waves in lead 2,3 AVF. That means they are not negative in 2,3 AVF. So it is not posterior septal, it is free ventricular wall. And you see QS complexes are there in lead V1. So it is again suggestive of left ventricular free wall. So this is, there is positive delta in V1 and positive delta in 2,3 AVF and QS in lead 1. So they are all suggestive of, this is suggestive of left and this is suggestive of free wall. So left ventricular free wall. The bypass tract is present on the left ventricular free wall. So let's look at this another ECG. What is happening here is V1 delta waves are positive, and so that means it is on the left side. Now next you have to see 2,3 AVF. In 2,3 AVF what is happening? The delta waves are negative. See, delta waves are negative. Delta waves are negative in 2,3 AVF means it is left sided posterior septal. So I'll write here negative delta wave, positive delta wave, positive delta in V1, that is left side, and positive negative delta in 2 3 AVF, that is posterior septal. So left sided posterior septal is the location of the bypass graft in this, bypass tract in this ECG. So next, one more ECG. See here, you have to see the lead one first. Here it is, so look at here, negative delta waves, that means it is on the right side. When it is right side, again you have to differentiate whether it is free ventricular wall, posterior septal or anterior septal. For that you have to see the axis. See here, lead 1 is showing positive waves and lead AVF is showing negative waves. So left axis deviation is there. When left axis deviation is there, anterior septal is ruled out, because in anterior septal normal axis will be there. So now we are left with posterior septal and free ventricular wall. For that you have to see lead 1. How to differentiate is lead 2 you have to see. In lead 2 whether there is negative delta wave or not, or there is positive delta wave. If there is negative delta wave, it is suggestive of posterior septal, that is 2 3 AVF for negative means posterior septal. If lead 2 showing positive delta wave or biphasic waves or predominantly positive delta waves, it is suggestive of free wall. So here 2 3 AVF are showing your negative delta wave, so it is posterior septal. So V1 is negative delta in V1, that is suggestive of right sided bypass tract, and negative delta in 2 3 AVF posterior septal. So negative delta in 2 3 AVF is posterior septal, whether it is on the right side or left side. Okay, next let us decode this ECG. See here, this is of course Wpw syndrome, and this is, you have to see V1 for localizing the accessory pathway. Here V1 it is showing negative delta waves, and for see negative delta waves. So once you diagnose that, so it is on the right side, accessory pathway is on the right side. Now you have to know whether it is on the posterior septal, free wall or anterior septal. For that you have to see axis. So lead 1 is positive, lead AF is also positive, so normal axis, so it is on the anterior septal of the right side. So negative delta in V1 right side, normal axis means anterior septal, so it is on the right sided anterior septal. So bypass tract is on the right anterior septal. So let's see this ECG, what is happening here. So V1 is showing negative delta waves, and lead 1 and AVF showing left axis deviation, and lead 2 is predominantly up or there is biphasic. So it is not on the posterior septal, so it is on the free wall. So negative delta in V1 means right side, left axis deviation is there, but left axis deviation is there, but lead 2 is biphasic or predominantly positive, so it is suggestive of, these two things are suggestive of free wall. So right ventricular free wall. Hope you are getting this, hope you are understanding this. So this is how we have to localize the bypass tract. So what is the treatment of Wpw syndrome? So Wpw syndrome, ECCH and European Society of Cardiology guidelines for the management of patients with supraventricular arrhythmia consider of ablation therapy as a class 1 indication for patients with accessory pathways that are symptomatic. So asymptomatic patient, you need not worry, and because some of the bypass tract are concealed or they are inactive, so they won't conduct. So antiarrhythmic therapy is there in these patients receives a class 2A recommendation. So what are the arrhythmias that are possible or that are associated with Wpw syndrome? The most common arrhythmia that is associated with Wpw syndrome is AVRT, and the other is atrial fibrillation. So this is all about Wpw syndrome. Here it's very important to know the ECG findings of Wpw syndrome and the accessory pathways, and You should know the how the conduction happens through the bypass tract and AV node, and the size of the delta wave, and the location of the bypass tract, and identifying the location on the ECG. So this is about WPW syndrome. Hope you understood this video. This information is useful for you. So if you like this video, please like, share and subscribe. Thank you.